All right, Dr. Castro Marin, I think we're all set.
Great. We'll go ahead and call to order. This is Protocols, Medications, and Devices Standing Committee on November 21st at noon. Shelley, can we get a roll call?
Amber Rose. Present. Erin O'Connor.
Present.
Brian Smith.
Present.
Chester Key. Bronco Castro Marin.
Present.
Garth Gamer.
Present.
Heather Miller. Jason Johnson.
Yeah. Here.
Joshua Gaither.
Here.
Mark Sampson. Matt Shaw.
Present.
Paul Zabrowski.
Here.
Philip Hannon. Shari Brandt. Here. We have 11. We have quorum.
Great. Just as a reminder, if you miss 2 or more meetings in a row, the Bureau will reach out to verify your desire to continue participation. At this time, let's go ahead and share the attendance report, which is attachment 3A. Currently, we have no vacancies. And then also, Shelley, if you could show the 2025 meeting schedule, please.
All right.
That's available online now.
Yeah, the dates that we scheduled are a little bit off of the normal Thursday cadence. So please, everyone take a look.
And if there's no questions, let's go ahead and start on the Bureau report, please.
Thank you, Dr. Castro Marin. Thank you also to anybody that's had to listen to me now 3 times, share some of these updates. If we go through some of these slides quickly, I just want to acknowledge that this week is Crash Responder Safety Week, with the theme being responders ahead, reduce your speed as you proceed. We did some partnering with local agencies and our sister state agencies on an event earlier this week to promote Crash Responder Safety Week, and most importantly, some of those training resources to help reduce accidents and injuries. And we hope everyone stays safe out there. Moving on to our next update. Again, we want to acknowledge our State Trauma Advisory Board and all of the committees that were part of putting together this year's annual trauma report. We just celebrated 30 years of STAB at our September meeting. And we really appreciate all the work everyone has done to improve our Arizona trauma system. The next slide acknowledges that we now have approached in 2024 50 trauma centers across the state of Arizona. And we appreciate you all and your contribution to advancement of that system. If you'll allow us, we'll talk about EMS portal changes with this committee. We do have quite a few changes that have either gone into effect or will be coming soon in the next 6 months. If you or your agency has a user account in Arizona's EMS portal or our hospital portal that is now hosted by ImageTrend, we want you to be advised of the following. The first is our EMS agencies can now more easily manage their rosters and secure who has access to their data by syncing up the portal with their EasyPeers Elite account. We have some informational slides on that are linked in this packet. And if you have any questions on that process, you may reach out to Ann Foxbury. Thank you very much, Ann. We also have been informed by the vendor that because of security changes, the email address for correspondence with the portal has changed. The email address that you would receive correspondence from through that portal is now avdhs@arizona.imagetrendlicense.com. It is a .com email address, not a .gov. And we share that with you because we hear it does not always make it through those spam filters at different agencies. So please flag that email address or let your agency know that they will need to flag that email address so you can receive correspondence from that portal. That would be confirmation that you successfully submitted an application, any follow-up or approval. So again, besides that email address, you're a user of our portal. We're also going through rebranding here at the state of Arizona. And by that, I mean, we are getting a new logo and a new color scheme. So you will see that our slides today have migrated from that red color that I'm sure that many of you are used to a new color scheme that's in the ballpark of like turquoise, purple, and copper in the great state of Arizona. So you'll see the logo on slides to come, and we look forward to working with you all too as we rebrand our certification card and our portal with that new logo and new color scheme. In other news, we wanted to share updates on job opportunities and recent promotions. Congratulations to Noreen Adlin, who has accepted the role of Deputy Bureau Chief. Congratulations also to Kim Bain, who has accepted the role of Section Chief of Trauma and Pre-Hospital Coordination. I know many of you guys know them and have worked closely with them, but I just have to say out loud that they have over 60 years of field experience between the two of them, and we're very fortunate to have them continue to work in their roles supporting the Bureau of EMS Trauma as well as our stakeholders across the state. My news to share with you all is that I am also moving into my official role as Deputy Assistant Director at the Department of Health, and that means the department is backfilling the Bureau Chief of EMS and Trauma System position. That is going to be available on azstatejobs.gov. It is an ASRS job opportunity for pension for anybody that is interested. We have the Bureau Chief role coming online for applicants. We will also have some additional leadership roles coming online for interested applicants. If you know anyone, have any recommendations, please send them our way. And we're looking forward to getting a qualified candidate that will continue to work on building those collaborative relationships that we've been so focused on over the last few years. So thank you very much for allowing us to share those updates. I just have one more slide, Shelley, if you can take us to slide 27. If you were with us a little bit earlier for the Education Committee, you heard us talk a little bit about the passion project that is the regional rural EMS training program that was funded for 2 years in a row. We wanted to highlight that that was a successful partnership that did result in over 120 certified paramedics in the state of Arizona that participated in that rural training program. This is a map that shows the EMCPs by county and the differences that we have by county across the state of Arizona. What we are targeting in the coming years is, of course, increasing all of our EMCPs, but especially paramedics, since the number of paramedics per population is much lower than our EMCPs overall. Right now, we do not have funding to continue that program, unfortunately, but we will be looking for funding. And in your packets is a summary of that program and those results should we identify funding to be able to continue. I next will turn it over to Dave Hansen and Julia Vinton. And Shelley, if you could take us to slide 30. This is where I hand it off to Dave.
Thank you. Just a reminder, if you have EMS agencies interested in the naloxone leave behind program, the link is on the slide and my contact information is there. Our update as of Monday, we have about 3,200 providers trained. I've shipped about 3,000 kits. And we have 47 agencies that are participating, and of those kits, we have about 400 scanned in. So if you're interested, get a hold of me. The training's free, it's online, best kind of training. Thank you.
And I can provide a quick update on the strategic planning. As you are probably aware, we've been working on this process for about a year now, with a little more time before that spent on needs assessments and things like that. So thank you all who have participated in that process. We are very excited to share that we did share the finalized draft of the strategic plan back at EMS Council in September, and that was approved by EMS Council. So the next steps are for that to go to the governor's office, and then we're planning to start work on implementing the strategies and things in the plan in January. So thank you again for all of your work on that.
Thank you very much, Dr. Castro-Marin. That should conclude the Bureau's report.
Thank you so much, Chief, and congratulations. Next on the agenda, our discussion and action items, starting with discussing, amending, and approving the draft minutes from our meeting on July 18th, 2024. That's attachment 5A. And can I have a motion?
Motion to discuss.
I heard Amber look there a second.
Yes. Thank you.
Any discussion?
Motion to approve, Mr. Amber.
All those in agreement to approve the minutes as shown, say aye. Any opposed? Thank you. That motion carries.
Can you do an abstention vote, please?
Oh, sure. Any abstentions on that vote?
Brian Smith is abstaining.
Thank you.
Thank you. Next item, discuss the process for updates to the drug tables.
A motion to discuss.
What's that?
I'm going to take my lunch to college, so I'll put it in the fridge too.
Oh yeah.
Yeah.
We have an open mic. Thank you.
So I can just cover this. We wanted to make sure that everyone was aware of the process. The last meeting, the group decided that we would have kind of a yearly review of any additional medications to be added. So Shelley has put together a very nice table. If you can scroll up, as we get submissions, we had kind of gone through everything that had been submitted through the process in the last round of meetings from PMD and MDC with substantial changes made to the drugs table. So moving forward, those go live and are approved on January 1st. So this would be, if you have anything you'd like for consideration moving forward, you would email Shelley, and then the process of how that would get approved would be at the bottom. This is just for us to have a good way, kind of one place to track this and make sure that we have a good history on that.
Cool. Thank you for doing that.
Any questions or discussions on this? All right, thank you. And thank you, Shelley, for putting that together for us. Next, can I have a motion to discuss upcoming updates for the scope to the scope of practice, drug tables, as well as certification and training rules for EMR and critical care endorsement?
I'll take a second.
And this is attachment 5C.
I can cover this quickly as well. This is just a reminder and a big thank you to this committee for really doing the huge lift over the last year of kind of taking in all the feedback that we had regarding scope of practice and drug tables and working with our medical direction commission. So this communication, if you're signed up for our Gov delivery, should look familiar. This has gone out via Gov delivery. This has the links to what will be our new drug tables and scope of practice. It also outlines the process for EMRs and critical care endorsement addition. We are not going to post the drug tables and scope of practice until January, just because we don't want two different versions out there. So the messaging that I've tried to share at the previous meeting is, if you have hospital-based paramedic, we have added a number of oral and topical medications, as you guys know, and were approved. And so those will go live in January. However, some of the more higher risk medications that are more appropriate for critical care endorsed paramedic, as per this group's recommendations, are going to be moved from the hospital-based paramedic to a critical care endorsement. So just wanted to make sure that everyone in this group saw these documents, and a big testament and thank you to all the work for this committee.
Thanks, Dr. Bradley. And the materials that you guys set up for this look great, by the way. So thank you for the work that went into that. I'm sure it was not easy. Next, can I have a motion to discuss the annual medication report, attachment 5D as in David?
So moved. Thanks.
And then first from Brian and a second from Matt. I'm lazy.
So Big thank you to Anne for producing these reports. This has been a request. She is finalizing and will finalize the 2024 medication. But I think it's useful as we kind of move forward and look at medications. Do we continue to include a medication in our drug boxes when we have asked sometimes to decrease the number of doses, the minimum quantity, add medications? You can look and see the frequency with which medications are given. So I thought it was quite useful. One of the things that was always interesting is you can tell sometimes we see medications that ended up in this list that are not on table one. When she runs the report, she realized either this was the wrong medication selected by EMS agents crew, or potentially it was not a 911 call. So the data is as good as what we get inputted. So we did eliminate anything that is not one of our approved medications for table one. There weren't many, but you can see here, obviously the most common we use medication, oxygen, saline, Zofran, aspirin. And then you can see some that go down to Thioretin, which at least for 2023 was 4 utilizations, oxytocin is 8, vasopressin 7. So I just wanted to put this in front of the committee. I know MDC has also asked us to see this, so we will make this available for MDC as well in January. But it's interesting when we kind of look at frequency with medication administration, especially as we build out the drug table.
Can I ask a question?
Yeah.
Is it possible that some of these were actually 911 transport and not in the facility?
There's two different tables. So there's the 911 and then there's in the facility.
Yeah, the facility. What I'm asking is, is it possible that some of these are just miscategorized as in a facility and there actually should be on the other table?
It is possible. I mean, typically we would see the interfacility should be coded as an interfacility, but it's how how that data gets submitted in AD pairs. So that is one of the limitations. There were, I think, a handful of medications, and there were limited numbers of each medication. Like we had some antibiotic administrations under the 911 drug table, which we know isn't in scope. So the question is, did they really give an antibiotic, or was it not truly a 911 call? So.
I have a question. I'm just curious, the albuterol and the ipratropium, I guess like I would have assumed that albuterol would be higher than ipratropium, but it's like 1,000 more. I was just curious if there were any thoughts on why there's that disparity.
I know it's a data entry thing, but it's just more interesting.
Yeah.
Like, are people giving that as first line instead of albuterol, or something? I think it's good data, because if they truly are, that might be an education thing that needs to be.
Or are they potentially giving multiple doses of albuterol and marking as one?
Like one, right?
And as opposed to,
Yeah.
that is a good point. I think we should put that down to kind of look at and see.
It may also be interesting to see if we do this year over year, like a percentage change kind of thing, to see if there's a trend in any specific medication going way down versus increasing, and might also help.
If we see the like the TXA education, seeing that it's actually being used more, being productive.
Yeah, so I know Anne is getting ready for the 2024, so we will be able to compare kind of year over year with that. So when 2024 finishes, she'll be able to have that data later on in the year. So that's, I think it's useful to look at this and kind of see, okay, with approved TXA, we start the increasing utilization and things like that. So we can definitely include this for our next meeting and follow ups.
I'll display the in our facility. And had her hand up.
Oh, go ahead, Anne.
I just wanted to say that if this group and Gail, if you have any ideas of something that you'd want to change, let us know. If it's something that we can do and feel confident in the way that we're displaying the data, we're happy to take feedback if you want to see something a little different for 2024 or whatever.
Dr. Bradley, this is Franco. Do you have any insight on the epinephrine 1 to 100,000?
Push those pressors.
Yeah. Is that, I'm curious too, is that like, because it's a range that you could administer. So is it count as 1 for every time, regardless of the dose, every time it's marked on the PCR? Is that how it's calculated? Okay.
Yeah, we don't have any insight in terms of how it was given or indications, so we don't have a way to go down to that granular level. It's
Mhm.
simply what medications were administered.
So they could have included all as one dose or 4 separate doses. Cool.
Thank you, Ann.
Yeah, and
I
this
guess,
table's limited, I think it says in the footnotes, but this was limited to, like I said, we could do it differently, but if it was given once or 4 times, it's recorded as one. This is kind of the patients that got these medications, or the calls, I should say, because you could have more than one EPCR per patient. We don't filter that out. But so it's not going to reflect if they got it 4 times, or like, like naloxone. It's in some reports where they got it 4 naloxone, they got 1. This is that EPCR said there was at least 1 administration.
Oh, okay.
Really, that they got 4 or 5 doses. I mean, if we want to do it differently next time, that's something that I can see if we can do that. But that's just how we've done it historically over the last 4 or 5, 6 years that we've done these reports, or however long it's been. But and one thing I will say that has been in conversations lately that I just want to point out, I don't have a solution for this, but some fire-based EMS, because we have 1 EPCR, will put what their engine gave us prior to arrival, which makes sense because the times there's only 1 set of times. And anything here that's given prior to arrival, that EPCR, if it says prior to arrival, it's not going to be included because we don't know for sure what kind of agency, or maybe it wasn't bystander or whatever that gave it. So that's something else that might slightly affect the overall numbers.
Brian, did you have a hand up?
And another issue with those numbers may be where people are putting those administrations to, right? Because I've seen some charts lately that everything with a drug is in the narrative. And it's not necessarily, it won't pick those up, right?
No.
Yeah, and narrative in general is, I mean, and I think Gail said this maybe in a previous meeting, but we get over 1 million records a year. So we look in the medications given field. And like I said, if they gave something 4 times, I've selected it down to 1 time. But yeah, it's, if they're putting it in the narrative, they should be putting it in the medications at least too.
and then another question is, would it be asking too much to change how the epinephrine is reported out? And could we, because we try to stay consistent with concentration rather than ratio expressions.
I mean, right now, and I'm not going to pull it up, and you guys probably wouldn't want to see it. And I can follow up later with however Gail wants me to follow up. But basically, there's so many different ways to say this, as I'm sure you guys know. And then we group them and say this is equal to this. But we do have things like, MIGs per mil or whatever available if they're filling it out. So depending on how reliable that is and how much people are filling it out, we could potentially go down a different path. And that's something that, I'm happy to discuss with Gail. If we can do what you guys are wanting to see, if we can program it, then we could try to see how it kind of spans out on this.
But I did have a question, just for clarification. What's the difference between the line that says epinephrine and all the 3 epis above that?
I can show you the exact programming too, but basically it's one where they didn't say, they literally put the drug as epinephrine. So we don't know. And like I said, we could try to dig in and see if we could figure it out. But that's why. So they're not specifying when they give medications given, they are saying epinephrine and not one of the ratios that can be subcategorized reliably.
Any other questions? And thank you so much for bringing that forward, and we're looking forward to the 2024 data as well.
I'll display the inner facility one, or no?
And this is not going to include anything that was given at the hospital, and they have to list this as they gave the medication. Just want to point that out because I know sometimes the numbers are going to look a little weird.
Well, this is very useful. Thank you.
Thank you. All right, any further discussion? Okay, hearing none, let's move on. Any agenda items to be considered for the next meeting? Please send those to Shelley, whose email is on the agenda. And then, of course, thank you, Shelley, for being the lead on the drug table rolling requests. So please don't forget to submit those along the way. Otherwise, we'll open it up to call to the public. Okay, so upcoming events. We are currently, today and tomorrow is the annual Southwest Trauma and Acute Care Symposium that you can participate online as well. Very high quality conference. Participated in some of those this morning myself. December 5th is the AIMS 5th Annual Fall Forum. On January 30th of next year, we've got the EMS Game Changers Conference here in Phoenix, and then March 3rd and 4th, the annual NAEMS Pediatric Symposium in Flagstaff. Next meeting for PMD will be March 20th at noon. And otherwise, can I get a motion to adjourn?
So moved.
Thank you. We will adjourn at 12:26. Thank you, everyone.
Thanks for the.
Oh,